Well, I thought that was just fabulous. Thank you to all of you. Incredibly thought-provoking, but also just I think it should give the audience really a full, well, a fairly full picture of the scope of the problem and where things lie. And so let me just start with one question to Ken. You talked a lot about the experience in Massachusetts, and I'm wondering if you can tell us a little bit more about your perception of some of the most significant barriers to more widespread adoption, not just in Massachusetts, but beyond Massachusetts, to some of the things you have implemented.
Of telehealth.
Yes, correct.
Okay.
Telehealth. Yep.
So telehealth, my take, it's going to happen. It's a question of speed of adoption. This is going to happen. So the question is, in my job now as a payer, am I helping to accelerate or am I helping to slow down the speed of this transition? A couple things I think need to happen. If you're a leader in the field and you're secretly squeamish about doing teletherapy, that's not going to promote adoption. I think it's pretty well established in the literature. It's safe. People experience it as the same kind of care. I meet with professional societies in my day job, and I have a leading person say, I wasn't trained on this. I'm not really sure. What if the patient gets suicidal? And so I think the anxiety of the leadership transmits down. Another thing is the payers have to figure out how to remove financial barriers. If you have to have a HIPAA-compliant platform, that's $30 a month per practitioner, ballpark, right? So this is one of the problems I'm working internally. The average practice is oversubscribed. So we say, hey, great, we have a telehealth benefit, but it'll cost you $30 a month to have a platform. Hey, I'm already oversubscribed. I already have a wait list. So that barrier, so there's a leadership barrier and an ownership barrier. I think there's a financial barrier. I do think that patients are also in a process of figuring out if this is okay. Can I do this thing from my phone? I do most everything else through my phone. Can I do this very intimate thing through my phone? Based on my experience with my 3 daughters, it's inevitable that they will do everything through their phone, right? I have 3 college-age kids. I mean, the phone is the center of their social life, academic life, financial life, hitting up the bank of dad for questions. So I'm very impressed at the power of this technology. And I do think the leadership of adoption, the payers removing some of the financial barriers will be important. And I do think the patients will adopt this. I don't know what else they need to do it other than to see it done. So if you're running a training program at McLean, are people leaving feeling comfortable delivering telehealth in your psychology, social work, psychiatry residency? Do you really feel good about it? Do you feel like it's the same kind of care? It is more efficient. It saves the patients time and money, and they might be able to do sessions while they're at work. This might help them keep their jobs. So there's some advantages. And for child therapists, which of course there's a dearth of, everybody wants to see their child therapist at 3 o'clock, 4 o'clock, 5 o'clock, and 6 o'clock. This is really crummy if you're a child psychiatrist and you have children, right? You actually want to hang out with your kids after school and do something with them, right? But of course, that's the time. So the question is, if teletherapy could improve your daytime efficiency, a child who needs help in a school setting, could they set aside 45 minutes for you to work with the child through telehealth during the daytime when you have to think of something else to do other than seeing kids, right? You have to get a job at a school. You have to do something else. So I'm impressed by the potential for efficiency in that regard. So I think it's going to happen. It's just a question of collectively the leadership in this room and in other rooms wants to accelerate improved access. I think it's actually a choice.
Thanks. While we're actually talking about telehealth, these are just a few more specific questions for anyone on the panel. What actually qualifies as teletherapy? That's one question. And also, what does the law tell us about telehealth? A lot of people have concern about crossing state lines and other things. And how do families and practitioners work through reimbursement-related issues? So that's yet another policy-oriented questions. I think these are perceived barriers, all of these, the law, reimbursement, and also I think people have some confusion about what exactly is teletherapy if we're talking about delivering interventions. So for anybody who wishes to address.
Well, there are a broad spectrum of teletherapies. There's face-to-face, pretty much a precise imitation of what would happen if someone were in the same room. There's synchronous passage of messages, so people could in fact do texting-related therapies. There's asynchronous, where in fact one can either send video messages back and forth in terms of response to various, or intervening in an asynchronous fashion, but with video present. There's audio teletherapy, which existed just with telephones before we had smartphones, and continues to exist. And anything that uses those tools in the broadest possible spectrum would allow that kind of intervention.
Thanks for that, and that actually speaks a little bit to the asynchronous and synchronous use, but yes, Oliver.
So Shelley, thank you. So just a couple of data points from other countries around the world. Switzerland was one of the first adopters of telecare, not just for mental health disorders, but for a range of medical disorders. And it's very, very common now, I think maybe becoming more common than a primary care consultation face-to-face. There's also a telecare service which covers most of Latin America, centered on Brazil, called SaluSpot, which has 20 million patients and 30,000 physicians on the back end. So more driven by necessity, largely the long distances to travel and the dearth of practicing clinicians. A lot of other countries, particularly in the developing world, have kind of leapfrogged over existing healthcare systems in the West and have adopted telecare kind of wholeheartedly.
So thank you for that, Ken.
The state lines is a thing, right? So if you're seeing a kid at Duke, you're technically practicing medicine in North Carolina. So I think the professional societies have to figure out how to help people with that barrier. It is actually a true barrier. It is, like all these other equations, solvable. It takes clarity of purpose. The states would have to collaborate. I know there's some New England state activity in the social work field to think about that differently. And until that happens, national companies are coming in with people that are licensed in every state, which is another way to do it. It's another disruptive idea, right? There are companies that will see any of the, let's say Blue Cross has 1 million people outside of Massachusetts. Your company's based here, but you happen to work in California. You know, if you want a telehealth benefit, there's a company that will provide telehealth anywhere you want. So that's an interesting kind of disruptive development to the traditional therapy model. It's a field that could use a little disruption, I think. I think we're on safe ground there. And that's an interesting, I think, potential opportunity.
I took a look at the several of the online platforms prior to this conference, and the subscription services for therapy are quite interesting because they have also different billing practices depending on how long the session. If you decide that you will have a 3-pack therapy package that you'll purchase and so forth. So as we get into this disruptive technology, it's also the case that it may be disruptive to our customary practices around billing and our way that we think about what constitutes a session and what kind of commitment a patient might need to make.
Can I say one thing about your point about the 3-session thing? One of the anxieties employers have is that when a person gets into therapy, it will be a lifelong commitment, talking about your childhood and your internal, introjected, maternal facets and your, et cetera, et cetera. What employers seem to want, it's not the only reason to do it, but it's compelling. What they want is short-term CBT devoted to improving coping to attend to a medical vulnerability so that your co-occurring psychiatric problem isn't compounding that problem. I know it's very financial, but a lot of us weren't trained on that model. And I think that's one of the anxieties, is that the field has to demonstrate a willingness to talk about short-term, focused, evidence-based treatment.
So thanks for those comments. I want to shift focus just a little bit and maybe have Kim and Gary from your perspectives talk a little bit about the impact of stigma and cultural barriers, about accessing mental health care globally. And I know, Kim, some of your comments alluded to this. How are we going to overcome those in terms of some of our digital and technological applications to delivering mental health care?
So it's both the medium as well as the content. So we have a way to deliver care at scale and remotely, but if the care package is not culturally sensitive, I think that level of engagement will be much decreased. So I think about some of the work of Maggie Alegria, who has pioneered the use of a short-term CBT approach specific to, or taking into consideration the interest and needs of Latina women. It's been delivered over the telephone, over cell phones. I don't know if there's a video version or not, but it's proving to be just as effective as in-person treatment. But it's not the medium that is really driving the outcomes exclusively. It's that the treatment itself has been designed for the population that she's most trying to reach.
So in the developing world, first, it's not just a societal and religious stigma and a local stigma, but also a policy stigma and the isolation of people with mental illness from the mainstream in terms of decision-making and empowerment. At the same time, the lack of services causes such tragedy to families that families become advocates. So many places in which we are, there are very, very small, centralized, extraordinarily inhumane and frightening mental institutions that keep people in circumstances worse than bedlam and without any hope of real therapy, treatment, or other intervention. And so many family members will chain their family members to their home so that they can be nearby, so that they won't run away, so that essentially they won't be harmed by society or be taken away. And they become great advocates for therapy becoming available in the community. And there's a real value to community health workers because they're people of those communities and those neighborhoods who know everything about a family. So they're great in terms of family planning because they know when a girl gets her first period. They know when somebody's left home. They know when somebody's ill, whose behavior has changed, and can work with the family to be able to bring those interventions and treatments. So there are various ways of working on stigma. One, working with traditional spiritual healers as well as church leaders and others to do educational intervention and to bring people together in those educational interventions so that they can also see somebody who's much better than they were before because of the miracle of that intervention and celebrate that in a way that adheres to promoting more and more therapy. Similarly, one can use what are less stigmatized medical conditions, whether it's family planning or perinatal care or child care, to be able to bring people together. So we have a set of groups in Caraballo, Peru, that are really focused on domestic violence and depression among young mothers, because domestic violence rates are about 70 or 80% in this community. These women are empowered. They have very high depression and anxiety rates, and the convening is around child care and around teaching child care skills, unburdening them from those activities, being able to create venues that then create permission for therapy.
Thank you for that. Yep.
Can I comment on stigma in the States?
Yep.
So anybody who has gray hair, have you noticed how people approach you as a mental health professional differently? So I have a little bakery at the end of the street, and I met up with some people I didn't know. Oh, Ken is a psychiatrist. He's going to read your thoughts and analyze you. I used to get this a lot. Now what I get is, oh, you're a psychiatrist? Can we talk about Seroquel? You're a psychiatrist. I need to talk about my brother. Has anybody had this experience that the conversation about who you are as a mental health practitioner is changing in real time? So I'm going to see 20 years ago, not one person would say, I have a real family history of problem X. You know, they would go with the, are you going to read my thoughts answer. Someone said that to me the other day in the bakery. I just met them, and I'm like, I don't think I've had a read your thoughts comment in or analyze people at the coffee in a really long time. And so, of course, the gentleman was over 65. And I just thought to myself, something is changing in our society, and we're all part of it. Now, I can't speak to anything in the developing world that's beyond my expertise. But in the States, I do think things are changing, and I do think it's for the better. And I do think technology will have to be one of the answers.
Yeah, and if I may, so I absolutely agree with that, not just in the United States, but actually across most of Western Europe as well. But from my experience in Abu Dhabi, I think there's a kind of nutty chicken and egg situation with regards to stigma. Because clearly if there are no psychiatrists and there's only a mental asylum and there are no community-based psychiatry services, it feels that society's saying something about what mental illness is and how it ought to be looked at psychologically by members of that community. And we found, not just in Abu Dhabi, but I'm aware of a number of other experiments elsewhere, where just implementing more humane forms of community-based psychiatry services itself creates a profound shift in the attitudes of people to mental illness. So I think it's important to be bold and courageous about implementing services in the right way, even if it doesn't seem that society's ready.
So Oliver, just to maybe follow on a little bit, you've talked some about the intrinsic scalability for digital technologies in the future, and but also the need to personalize that care. So I'm wondering where you see the first frontier of the use of this technology to radicalize care. And for example, like, would you focus on a type of treatment, a specific population, a specific diagnosis, a specific point in the time trajectory, or other? Because it seems to me to move us from all of the discussion we had yesterday, which was on many of the different kinds of promise of the technologies, to beginning to fit those into the scope of the problem that we've been discussing here today. Some of it is, where is the next steps along the way, and I'm just wondering if you have some thoughts about it.
Yeah, thank you. So my inner McKinsey consultant is screaming out for a 2x2, right, where you'd have impact along one side and maybe kind of appetite on the other side, and then you'd be launching into the top right corner with gusto. The reality is that that transformations and disruptions happen in unpredictable ways and in ways which are not always perfect. But what I would say is that I think this revolution actually is underway already, and we've talked about teleconsultations and teletherapy. We're really excited to see that the FDA has just regulated a substance use disorder CBT tool, and we believe that CBT is going to be a really important form of therapy for some of the reasons that we've touched on here, but also because the combination of a structured approach combined with the ability of a smartphone and the sensors in the smartphone to not just personalize the service, you can choose the color of your screen, the images which kind of resonate for you, but also to monitor treatment response and be adaptive to treatment response. You've said you're going to try an exposure. You haven't actually left your apartment. You haven't tried your exposure. Let's try that one again. So there are I think a small number of therapies which are intrinsically digitizable. That's not too bad a word. And those would be the first place to start if you had a 2x2. I think what it falls to us to do as practitioners and those with an interest in technology is to embrace what we see. Expect people not to get it right all the time, but to try to be on the side of the angels and saying, here's what you might like to try better, and try to avoid becoming naysayers and saying, this is what happens if you try to digitize psychiatry. I think we should all be trying to push this forward.
Thanks for that. Somebody asks the question, is there actually evidence to show that improving access to behavioral health care, especially through digital technologies or virtual or telehealth or teletherapy, actually will reduce emergency department visits or hospitalizations? Is there data to support that?
Not exactly.
Say again?
Not exactly.
Not exactly.
Right, so the whole idea of increasing access to behavioral health, developing a return on investment on the medical side, is a working assumption we all have. In general, that literature is semi-unsatisfying. And I'm open. If anybody finds a better paper, there was one RAND study which hinted at, if you have a better paper, see me afterwards. So increasing access may or may not save money that is directly measured. It may improve workforce productivity, presenteeism, absenteeism. It may help families stay together. It may reduce incarceration. Now you're getting into social problems, which are bigger than, TME, total medical expenditure. It is well established now that people with co-occurring mental health and medical vulnerabilities consume a disproportionate amount of services. I would say the holy grail in my line of work is to figure out how to develop something that works in relatively short order, that people will adopt, that will help reduce comorbid medical vulnerability. So I don't think it's well established at this point. I think it's a literature that is crying out for a definitive solution.
So I see Gary ready to go here. So
I have a political response
yes,
first.
Yes.
First, the benchmark for improved healthcare outcomes and public health outcomes, even in the most financially driven sense, can't be total medical expense. So, number one, the United States has the largest expenditure per capita on healthcare. But if you add expenditures in the social safety net, which relate to the social determinants of health, which are the most important predictors of public health outcomes, the United States is 12th or 13th. And so using total medical expense as a measure of how it is that one leverages overall health outcomes, reduces burden of disease or function in society, is cynical, even in the sense of the outcomes that we all embrace and want to have, even from the perspective of the greediest employer, who's focused in the narrowest sense, because he or she is going to lose in the other domains. Second is, even on the TME side, the notion of measuring everything in averted emergency room visits for psychiatry and psychology doesn't apply, because we're just allowing disability and non-acuity, and it's only a very tiny subset who end up with hyperacute services. It's most people who end up with nothing, like the 90% of people with addictions that you identified.
Right.
So we need to kind of move in both ways, I think, away from those measures and focus overall on, if we're going to focus on any expenditure overall, it needs to be total expenses, including social safety net, because some of the problems you described can't be measured specifically in transactional costs associated with other treatments or even comorbidity.
So I would agree with that, and I think it's in some ways it's a population level replication of the individual approach, which is to reduce symptoms without paying attention to function. And it's really the same, and we've had a very reductionistic approach to doing that, and it's been hard to get clinical trials and other things to look at patient outcomes that go beyond the reduction of symptoms and actually approach function. And I think you've identified a population health equivalent to the same thing, which is that we're really looking at health across the lifespan. And when we start to look at outcomes for patients and families, when we're looking at health outcomes across the lifespan, I think then we'll begin to be able to calculate the benefits of providing the care to families and patients, and doing that both in some instances face-to-face, but in many instances augmented by telehealth, augmented by digital technologies, sometimes replaced completely by digital technologies depending on the place, and hopefully with a very clear focus on regaining and gaining the trust of populations that have typically been excluded from our field, and for whom there is very minimal trust, if any at all, which really restricts us from being able to really assist in any meaningful way for a good many people. And it is perhaps in that realm, I would think, that digital technologies, things that can speak directly to patients or to individuals, that leapfrogs over certain things, may actually begin to break some of that down, as long as those individuals up front are consulted about their needs and expectations and what they would wish to have included, I think, in their in what's being provided to them. So that's a great challenge, I think, for the field overarchingly. It's a tremendous challenge, I think, for people who wish to begin to bridge this divide in telehealth, telemedicine, digital technologies. And I think it's truly important, both, I would say, in the US and globally, and sometimes we talk about low and middle income countries and the significant need there, we skip over some of the statistics that Gary provided about the lack of services in so many areas of our country here too. So sometimes things are very different and sometimes they're so much the same. I don't know where we are, but I'm getting a tap to the watch over here by Laura, our fearless leader here for this afternoon. So with that, I want to thank the panelists for everything they've said and all of you.